Hello, welcome everyone to the final Diabetes Health Matters with Dr. Joan St John of the season. Today looks a little bit different, doesn't it? Because normally it's Dr. Joan St John opening us up today. Today it's me. My name is Dr. Bernadette Adeyileka-Tracz. I'm the Executive Director of Diabetes Africa. We're a non-profit organisation that seeks to improve diabetes and related disease outcomes for everyone based in Africa and the Caribbean and people of Black, African or African Caribbean heritage globally. This series, if you've had the pleasure to join us over the past 4 years, we do a range of topics just to upskill people living with diabetes related diseases, their loved ones, carers, and also healthcare professionals on the topics that mean so much and that everyone should know about. This series wouldn't be possible without the support of Eli Lilly and Company and also Aim Marini. So we're very thankful for their support, but they haven't had any input into what we talk about and the speakers that we reach out to. So without much ado, I want to reintroduce, even though there's no need to, Dr. Joan St John, who is an spectacular human being, but apart from that, she is a GP with an extended role in diabetes. She's worked in primary care for a significant amount of time and has worked on projects that have had huge impact to the lives of people living with diabetes, such as the Carbs and Cows World Foods Book, which you've probably heard of, which is one of the best resources for people who don't eat a Western diet. She's also done other incredible things over her career, but a short snippet. She's got a new project at the moment, the 100 Black British Doctors, with her organisation Future Medics Forum, which is doing great things as well. I know that's not covering everything, Dr. Joan St John, but just a sneak peek into why you're so fabulous and why we're going to have a fantastic episode today. Welcome.
Thank you so much. What a welcome. That is amazing. I'm thinking, is that me? Thank you so much, Dr. Bernadette Adeyileka-Tracz. I really, really appreciate it. And I really appreciate everything you do in Diabetes Africa, producing this wonderful webinar series, Diabetes Health Matters, for all of us.
Thank you so much, Joan. And like I said, we've flipped the order today. And so I'm going to be walking Dr. Joan St John through the clips. We're going to be discussing, and we'd love to hear your comments and feedback in the chat. Let us know what's interesting, what you agree with or disagree with, and we're going to answer those questions either in the chat or the Q&A at the end. So, shall we kick off?
Yeah, let's, because it was really exciting. There was so much that we learned this season.
Yes, absolutely. Right. So, we had the fantastic Dr. Jean-Claude Catté, who joined us to talk about the different types of diabetes. And we're starting off with type 1 diabetes. So let's get into the clip.
The setting here is in Africa. And I actually led this research that started back in 2018. And with our team, we were able to find that among young people who present like type 1, like they've got type 1 diabetes, within that group in Africa, there's actually 2 distinct disease groups. We have a small group of young people presenting with true classical type 1 diabetes like seen anywhere else in the world. But the majority of these young people in Africa have this atypical form of diabetes, I would say, which is new because it's not type 1 when we've looked at their genetics and their immune profiles. And it's not type 2 because people who have type 2 diabetes are not insulin deficient to the point that we have seen in this in Africa, in these young people, and they don't have the BMI profile that they look like type 2. And we went further to check their genetic component, whether it looks like normal type 2 diabetes, and it was different. So we think that this is actually a distinct disease category found in these children and young people in Africa.
That was an incredible finding by Dr. Jean-Claude Catey and his team. Joan, do you want to have any comment on that and what it should mean to people?
Well, first of all, I have to say, I think it was one of the standout moments of season 4. The fact that we could have groundbreaking research, novel information brought to light by the lead investigator, the principal investigator. It was quite amazing. And he is quite amazing in his description, his clarity of this novel type of type 1 diabetes. So not the typical type that we would expect to see, that he's found through his studies in Africa, in Cameroon and other areas of West Africa. And it was groundbreaking. It was phenomenal, and I don't say that lightly. So yeah, it was absolutely great. Watch this space. We have to have him back for further seasons, definitely, to see how this develops. But to be at that cutting edge, at the beginning of this arc of research and investigation, it was wonderful.
Absolutely, Joan. And what it means for me is, for people living with diabetes and their loved ones, carers, is that if someone has been diagnosed with type 1 diabetes and it's not following the typical trajectory, or it's not presenting the same way, it's worth a check, a recheck. Like you said, the field is developing and we're getting more insight into what that means clinically, but it's not so straightforward as, yes, type 1. There might be types within that. So thank you so much, Dr. Jean-Claude. We're going to have you back to talk about type 2 diabetes this time and getting the diagnosis right in that subtype.
The lines between type 1 and type 2 can be blurry. For example, if you're a young person and you from black heritage, for example, and you live in the UK and you go to the hospital and you're sick and you've got diabetes, if your BMI is low, naturally the doctor might think that you've got type 1 diabetes, but you may have lean type 2 diabetes. And so what we see occurring always is that young people who are non-white may develop type 2 diabetes, but they are labeled as having type 1 diabetes either because they presented with ketosis or because they are lean. But generally, it is known that about 40% of young people are misdiagnosed as having type 1 diabetes. Well, meanwhile, they've got type 2 diabetes.
And I find this clip important for a number of reasons, John. Number one, he said, we think 40% of people living with type 2 diabetes may have the incorrect diagnosis, which is huge. And the second of all, once again, like the clip before, if something isn't quite right, let's get a double check as we find out more. Joan, what do you think?
Yeah, absolutely. And I think the sort of summary of this and the summary of Dr. Jean-Claude Catey's episodes is that those lines are blurry. I mean, he says it in that sentence. So the criteria for the diagnosis of the different types of diabetes, I think, can be blurry. You can get somebody who will have a typical presentation, typical pattern of symptoms, signs, progression or not progression. But then there are people who don't follow that pattern. And I love that, it's blurry, because as clinicians, it's not always clear cut. And so, we have to just be aware that if things aren't following the pattern that we expect them to, just have that open mind. There are all these different types of diabetes and we're learning more about different subtypes. So just keep that open mind for clinical diagnosis.
Absolutely. And if someone is very slim, it might be a trigger for an extended conversation. this person's very slim, or I'm very slim, I have a diagnosis of type 2, let's have a conversation. And along this, another example of maybe a less commonly found subtype of diabetes, we're going to be talking about ketosis-prone type 2 diabetes, which we know is a lot more common in people of Black, African, Caribbean heritage.
Tell us what we mean when we say ketosis-prone type 2 diabetes.
I've been looking at this recently, just looking at the data. So this was first described early on, in parts of the Caribbeans, in also parts of Africa, parts of Africans living in the US, where clinicians found out that there are individuals who develop diabetes with ketones, which, contrary to what was taught back in those days, was that we would only have ketones in type 1 diabetes. And so it was said that there are some individuals who tend to present with both features of type 1 and type 2 diabetes. They also noticed that these individuals were not overtly overweight or even obese, as one would naturally see or traditionally see in people who develop type 2 diabetes. And so when they started studying in depth this form of diabetes, a typical form of diabetes, they found out that it was common in non-whites, as you rightly mentioned, people of African ancestry who were middle-aged. And remember, middle age is something difficult to determine nowadays, but usually around the ages of 30 and 40. And they were insulin deficient at the time where they were diagnosed with the disease, and to the point where clinicians had to administer insulin. So they were insulin requiring at the onset of the disease. They would usually have a strong family history of diabetes. They were mostly males, and as I said, they were not overly obese. But one of the most important things in the definition of this type of diabetes, ketosis-prone, is the fact that after that initial episode of ketosis, they would usually go off insulin and may probably stay off insulin or even off their oral medications for a period of time. So there's some sort of a reversal of the ketosis, and they would stay without insulin for a long period of time.
I love that clip, Joan. Okay, firstly, I'm a bit upset that he called me middle-aged, but apart from that, it was a fantastic episode, and we saw the quality of Dr. Kate's presentation. But I think the main take home for me from that session is that if someone feels or sees that their insulin requirement can literally switch off and back on again, have periods where they're okay on tablets or perhaps nothing, as Dr. Kate said, and then need a high insulin requirement, that might be an indication that something is not as it seems. Joan, what was your takeaway from that?
So I think it was about my experience, really, in terms of being a primary care physician. So what we would see is that person had, unfortunately, usually an admission to secondary care because of the ketosis and the need for insulin. In the acute setting, they would be cared for by secondary care. But then, so in a hospital, then they're coming back to us in primary care. And that's when we see the requirement for the insulin drop dramatically, that people may then experience things like hypoglycemia, so the blood glucose is going too low. You are then questioning, do they need insulin still? Maybe they can either go back to their oral treatment or start on oral treatment. The conversations that you need to have with that person about why and the rationale for why you're doing that. And what also the other thing is, what the precipitating factor might have been that push them over into ketosis, which is really important, because it's vitally important that that person is aware of that thing. If it's an infection or something else that tipped them over into ketosis, they have to be wary of that, because they can get tipped back into ketosis again.
Yes.
So yeah, it was more about the experience, because I can remember those people who have presented in this way, and the conversations we've had and the strategies that we've used together to keep them safe and keep them healthy.
Absolutely, John, and thank you for sharing your personal experience of what it's like as the healthcare provider caring for these people living with diabetes. But I guess the take-home message for people living with diabetes, if something doesn't seem right, go back and have a conversation. I guess likewise for the care provider, if something is just not making sense, might be worth a recheck. A huge thanks to Dr. Joan St. who's provided us so many. That was just a snapshot of the gems that he shared with us over the first 3 episodes. So thank you so much. We're now going to be moving on to the fantastic Nana Okran, who is hands-on implementing lifestyle medicine in people of Black, African and African Caribbean heritage. And we're going to go to the clip where she's just explaining what the impact of lifestyle medicine can be on people living with diabetes.
So if you look at these lines, these are all real patients. Each line represents a patient, a story, and the way they've managed to make those changes and see what is better outcomes. Maybe that's the right expression. And so you can see that they are all moving the same direction, even though they're all different.
It's a very powerful picture, because I'm looking at all those lines that make up individuals and aspects and times within an individual's life. These are people who are living with diabetes, type 2 diabetes, I presume. I can't actually see a line that is going up. I can see lines which are going down more slowly. I can see lines which look as though they're almost static, but I don't see any lines going up, which is what we can see if nothing is done. So yeah, it's quite a powerful graph.
We had a question about the downward curve for HbA1c that you showed. How long does it take to achieve the results that you presented?
That was such a wonderful question. So everybody is different. So it's not as if everybody achieved those results in 3 months. Some people achieved it in 3 months. Some people achieved it in 6 weeks. Every single person achieved it in a different time frame.
John, I am so mesmerized by lifestyle medicine and so pleased to hear that it's being used more and more to support people living with various conditions. And of a baseline, I love Nana as well. She's fabulous. But it was so encouraging to see lifestyle medicine, which includes looking more holistically at a person and the things that impact one's ability to be healthy, to have a healthy metabolism. So we saw the lines going down and we saw that the timeline varies. Joan, what's your view on lifestyle medicine and diabetes with a cultural twist?
I think what lifestyle medicine here is a focus, is time, is much more holistic than we have done previously. So yes, we will try and do lifestyle medicine, but Nana is actually doing lifestyle medicine, spending time with people, building up a relationship, understanding their circumstances, so meeting them where they are and then seeing what is possible from where they are in order to make some changes so that you can get those improvements. If you imagine that graph had been for a treatment or a medicine of some sort, it would just be so incredible that everybody would want it. It is absolutely fantastic to see people making an improvement, because you don't often see that. And there's 51 people that she represented in that graph. As I said, each and every one of them seemed to make some improvement. That is incredible and amazing and wonderful, and that is really what we want to see. That's really what we want to achieve together with people who are living with diabetes, that we can somehow assist them to make some improvement.
Absolutely. And I know we've just had the brief clip about lifestyle medicine. If you'd like to have the full story, please go to our YouTube. Hopefully one of the team can put the link in the chat. Go and have a look after this episode to learn more about lifestyle medicine.
The only other thing, sorry, Bernadette, I'll just very quickly say, I love that it's called lifestyle medicine. So you're putting those two things together, because medicine is normally thought of as like medicines and medications and all of that. Yeah, I love that it's lifestyle medicine.
Absolutely. Complementary.
Absolutely, yeah.
No, we are shifting tact. We're going to be having a few clips on women's health. Women of vintage, shall we say, Joan? Vintage, women of vintage focus here, which I love and we need to have more of. We're going to hear from Dr. Itunu and Dr. Aziza, who are going to be speaking to us about menopause and diabetes and all the different aspects. We're going to kick off with falling estrogen and rising resistance.
I think it's important to understand that as our estrogen falls, because of all the things that we've talked about, there's a metabolic change in the body and it reduces insulin sensitivity and increases insulin resistance. And then with this weight redistribution that we've talked about, and also counteracting muscle loss, which happens in the menopause. So we've talked about bone density loss, but muscle loss also happens as we get older. And so all of that means that the body is struggling to use glucose as effectively. And that means that insulin is working harder, and we get insulin resistance, which increases the risk of type 2 diabetes. And so that means that, with the hormonal changes, we are at increased risk, if you've already got diabetes, of getting poorer control. So you might suddenly think, why is my HbA1c rising? And it could be as a result of this. But also, if you are pre-diabetic, it could be that thing that tips you over the edge. Now, we know already that Black women are 3 times more likely to have diabetes anyways. And so we are at increased risk of this compared to our counterparts, in addition to South Asian women.
One of the reasons I love this clip is it helps to remove some of the blame that people might have felt, during that period of time. It must be so challenging. Dr. Tunu spoke about the muscle loss, the reduced sensitivity to insulin. I know in that episode we talked about bone changes. Oh my goodness. And then on top of that, an individual might be newly diagnosed with type 2 diabetes or see that they're less able to manage their diabetes. Must be such a difficult time. Joan, what are your thoughts on the episode?
Yeah, I just thought, again, this was a wonderful part of Series 4, these hormones and diabetes episodes. And Dr. Itunu explained it so well. And as you said, it took away that self-blame. She gave the physiological reasons why these changes happen, and took away that self-blame that some people may be feeling. So, I just thought the clarity of the explanation, Dr. Tunu and Dr. Aziza, wonderful combination, and we're going to hear more from them as well.
Yep. On that note, we talked about the blame, the emotional side, so let's get on to the next clip.
And there were questions about approaching all of these changes that what you call the change, Dr. Joan. This can be very overwhelming from a mental health perspective. What is your advice, Dr. Isioma? How do you approach this from a personal management perspective?
I think it boils down to giving yourself grace. And sometimes, some days sometimes it's really overwhelming and you need to cry it out. You need to find your safe spaces, people you can talk to, trust. And then some days are for action, some days are for crying. We need to think about ways to look after ourselves individually, but also as community, whatever that looks like for you, what is appropriate in your own cultural or individual context. We talk about managing stress. I am a big proponent of lifestyle medicine, but I know that for some people, lifestyle medicine doesn't make sense. How can I, with quote my conscience say to somebody who's working 3 jobs to try and manage their stress or to sleep better and there's a single, it's really hard. So we need, as a provider, what I need to know is more about my patient's, I guess, social context. And I encourage people to explore what better sleep or stress management looks like for them, or even exercise. We talk about walking and going to the gym, but for some people, the gym doesn't make sense. It's not appropriate. What about, with regards to when you do your shopping, how much and how many bags are you carrying? How far can you walk with the shopping? So it's about taking a personalized and holistic approach that obviously touches on the pillars of lifestyle medicine, but that ultimately makes sense to people.
I so love Dr. Isioma Okolo. She's just fantastic. I just wish she was my doctor. But I love this clip because, rest and just allowing an individual to just go through things, not have to be strong. I know we have this strong Black woman label, which in some ways is positive, but just I like how she even said some days are for doing and some days are for crying, and just to rest, and also that personalized approach.
Yeah, absolutely. As she says, give yourself grace, and some days are for doing and some days are for crying it out, and that may be the way that you can manage these symptoms. I know we're going to go on to talk more about how different ways that you can manage, but actually that is such a beautiful sentiment and sentence. Sometimes just give yourself grace. And yeah, it was wonderful to hear her outline that, and again give permission. That some people feel that shouldn't be the case, but actually just giving permission for that. So yes, she is fantastic, and we were so privileged and blessed, I'm going to say blessed, to have these 3 wonderful speakers talking about hormones and diabetes. It was amazing.
Absolutely quality, as you say, John. Absolutely. So we're going to touch briefly on nourishing one's body in that context.
Nourishing your body. And I think this is really important because a lot of the time when we hear this, particularly as Black people, we feel it comes with a lot of judgment. And I felt this myself, so I know what it's like. And I think I want to say this with a lot of love, right? This is not about judgment. This is about loving your body with the food that you eat. And this is about recognizing that the food that you eat makes a huge difference to how your body responds to these menopausal changes.
John, before I hand over for your thoughts on that, loving your body with the food that you eat. Not gonna lie, sometimes I've had a stressful day. That is not the way I'm thinking, but it absolutely should be the take home. Joan, are you going to confess to anything? Or you don't have to, but yeah, what's your talk on that?
So, in previous episodes, we've had about mindful eating. So that was something that always stayed with me. And I'm not saying I always achieved that, not by any means, but it's there. It's lodged in my head. And this also has lodged in my head, because what I like about it particularly is it's not about don't eat this, don't eat that, don't do this. It's about celebrate and nourish your body. So it's a positive thing by the foods that you eat. No, we're not always going to achieve it, but at least it's something, excuse me, to aim for.
I'm going to try and keep that in mind, John. Anyway, moving on. So, tackling hormonophobia, which the simple way of that is the aversion or being a little bit wary of taking external hormones, such as the pill. So we're going to dive into that topic now.
Hormone replacement therapy is the best evidence-based treatment for people experiencing symptoms of perimenopause and the menopause. Now, of course, there are some women, it's a small group of women who can't have HRT for lots of different reasons. So maybe they have a hormone-sensitive cancer, or they have some kind of medical problem that precludes them from getting HRT. But for the vast majority of women, HRT is safe and an evidence-based treatment for the menopause. But of course, with our community, and this is why I've put the word hormonophobia and I've put it in inversion marks, is that hormones are, there's a lot of fear around hormones, and the fear is, oh, hormones are dangerous, they cause cancer and they should be avoided, or even hormones are not for Black women, they're not for us. And I want to tell the truth, which is that HRT can improve insulin sensitivity and can reduce symptoms and improve quality of life in the menopause. Now, everybody doesn't have to have HRT, and I think I need to be really clear about that. But for those who are really suffering with their symptoms, it can really be life-changing and quality of life improving. So the main risk that people worry about is breast cancer. So for the vast majority, under the age of 51, that risk is really almost non-existent. Now, over the age of 51, there is a slight increased risk of breast cancer. We say 0.5 to 1% over and above your background risk. Now, your background risk, if you've got a genetic inherited condition, or you've got a strong family history, or you are overweight, or you smoke, or you drink alcohol, your background risk is already increased. The addition that combined HRT adds is only 0.5 to 1%, so 5 to 10 in 1,000 women. So these are very, very small risks. And the increased risk of womb cancer and ovarian cancer is even lower than that.
Just in a few sentences, what are your thoughts on that? I mean, she said it all, really, but is there anything you want to add?
She did. So, hormonophobia, as a term, I think has some uses, and it's something that I hadn't heard before, but I think it is quite a useful thing to bear in mind. Also, the fact that one size doesn't fit all, there are other options. But what I particularly loved was the clarity, because that clarity brings information, and then you can make an informed decision about whether or not HRT is for you or not. But at least it will be an informed decision. So yes, she said it all.
Absolutely. And you use the key phrase, one size doesn't fit all. And our next clip is exactly on that, when we were talking about it's not PCOS anymore, PMOS. Yes, so bear that in mind, forgive us. This is a recap. We know it's PMOS, contraception and diabetes.
One size does not fit all. We need to look at the intersections, because you're getting the triad of hormones, you're getting the weight gain, fertility issues, and the blood sugar changes simultaneously. And so there are complexities in what we're able to prescribe to you as a patient, what contraceptive choices are best for you, which we'll elaborate later on, because they can directly impact your weight, your mood, and your glucose controls, the very thing that PCOS patients are struggling to manage. So we need to look at that. We also need to look at it with a health equity lens. Now, PCOS and diabetes are more common in Black women, sadly. I feel like every time we talk about Black women, it's always we're 3 times, 2 times, 4 times. We're more likely to develop a lot of these conditions. And majority of the times, even healthcare professionals don't seem to be aware of this reality, which then has an impact on our ability to manage the symptoms.
Joan, any comment on that?
The only thing I would say is that it's now been termed polyendocrine metabolic ovarian syndrome. I had to look it up because PCOS has been around for a long time, but is now changed to reflect those metabolic changes that you're seeing with what used to be called PCOS. So yes, I think Dr. Aziza, the intersections, all those different about health equity as well, just brought it all in. Yeah.
Absolutely. Because I found out the other day that not everyone with PMOS has cysts in their ovaries. So that is a well overdue and welcomed name change, and we will the next time we talk about it, it will be PMOS. So next step is, what can we do about it?
What can we do about PCOS in this context?
One of the things that I think is really important to understand is that even just a 5% weight change, so whether that's a gain or an increase, can impact PCOS hormonal symptoms. So a 5% weight increase can make symptoms worse, and a 5% weight decrease can make symptoms better. So this is why lifestyle is so important. And so when you go and see the healthcare professional and they're talking about lifestyle, again, I know sometimes it can come and feel like judgment. It's because the evidence is so clear about this, and we can't get away from it. So again, it's about nourishing your body with the right foods, and we talked about that in in the previous episode, building metabolic strength and physical activity and movement, all the different types of movement that we talked about. But resistance exercise is so important here because it can help to improve insulin sensitivity and metabolism, because when you're increasing muscle, you're working against the negative metabolic changes that are coming from the PCOS condition, which is, as we've discussed, the hormonal condition. Now, supporting your hormones with rest. We've talked about sleeping, which will help you regulate your hunger hormones and help you manage stress. But all the other things that we talked about in the previous episode about how to manage your mental load, nature, about, support and getting help, all the therapy that you might need to manage any existing trauma. So important.
Yeah, and I love Dr. Joan. I just love how everything's weaving in with each other. Across all the themes, we're having commonalities. And Dr. Tuna was talking once again about how small changes for an individual can have a huge impact, bringing in the sleep, what's the quote, loving your body with the food that you eat, etc. I just love that.
Yeah. Absolutely. And, lifestyle medicine seems to be one of the strong themes coming through this series of episodes. It really does. And I'm glad that we put more emphasis on that. As I said, it is vitally important if we're talking about helping and assisting and advising people who are living with diabetes.
Earlier, when we had the clips from Dr. Adeyileka-Tracz, we talked about how there's emerging evidence coming from the research, and some people might have been asking, well, why are they just emerging now? Why didn't we know all this before? We're going to touch upon it here, but often also the research did not include or have representation of people from Black, African Caribbean heritage. So we've got the fantastic Dr. Veline Esperance, who's going to be telling us about research and why it's important.
And why is it important to take part?
Well, it's important to take part because research is used in order to define how we put clinical practice in place, what guidelines we use, what tests we use, what drugs or interventions we give. And if we're not part of that journey, then we're not represented, for example. So it's really important to participate so that data from Black communities are included in research. And when we think about diabetes and we look at the scale of the problem with diabetes, there's a lot of health inequalities that are faced with Black people with diabetes, and research can be used as a means of correcting that.
So, Dr. Veline, if you've convinced me, okay, and if I want to participate in research, what's likely going to be my next step?
I think the first port of call could be your GP practice, because they may have a list of different studies that are currently being run in the area, or your hospital consultant, for example. And then you can look and see what various research appeals to you, and that can be based on whether it's a research question or disease area that's important to you, your family, your community.
Absolutely, well explained, Dr. Veline, about why it's so important. And I think, Joan, people hear research and, for a lot of people, it can sound invasive or, and there's legitimate reasons why people feel like that. But moving forward, I think Dr. Veline puts it beautifully. What's your thought on that, Joan? And also going on to the next topic about the scale of the problem.
Sure. So, Dr. Esperance, she explained it so wonderfully. But if we think back, how could we have the knowledge that Dr. Jean-Claude Caté had shared with us if there hadn't been Black voices in that research? How could we have the information that Dr. Aziza, Dr. Isioma, Dr. Itunu shared with us if there hadn't been some Black voices to know that Black women experience the symptoms of the menopause more frequently, more severely? How would we know that if Black women hadn't been involved in that research? lifestyle medicine is also evidence-based. So again, the research is coming through there. So this underpins and is like a sort of thread that is going through all of the episodes that we've had and the ones that we will review subsequently as well now. But yeah, it is so important for us to be involved, because how can we know that whatever this is, whether it's about the menopause, it doesn't have to be about a treatment, whether that is the case for us unless we're part of that.
Absolutely, John, and thank you for giving the examples to just bring it to light about we only know what we know because people have volunteered. It needs to be done the right way. We're not saying that we should just get involved in research anyhow. Mm-mm. So there are checks and balances. But thank you so much, Dr. Veline Desperance. Our final episode in this compilation. Fantastic Dr. Victor Ogontolu, who he's done so much work, and he's a consultant diabetologist. One of his key areas is diabetes in the young. After Jean-Claude Cathy called me middle-aged, I don't know if I'm young. I think I'm in the young middle-aged group. So many of us are. But we're going to just touch on briefly about young people living with type 2 diabetes and the link to complications, and just expanding, learning a little bit more about this. So let's hit the clip.
The reason why people with type 2 diabetes at early onset have all those sort of issues that you mentioned is, first of all, it's a disease that's diagnosed earlier, so you're more likely to live with it for longer compared to somebody who was diagnosed in later life. That's one thing. The second thing is that actually at diagnosis, we often see more association of comorbidities such as cardiovascular and renal disease in those who are diagnosed earlier. And it's actually, there's some evidence that shows that the pathophysiology of type 2 diabetes in people who are diagnosed early is slightly different from those who are diagnosed late, i.e., they can present with things like microvascular disease. What does that mean? Kidney disease, eye disease, nerve damage, which can be seen earlier in those who are diagnosed early. And the last thing is that people who are diagnosed at an early stage are less likely to live longer. So there are studies that shows that young adults with type 2 diabetes actually have about 13 years reduction in their lifespan compared to those who are diagnosed at old age.
Wow. So, I mean, that is quite sobering to think about. So it's particularly important then to identify somebody at this young age who might then be living with or at risk of developing type 2 diabetes. And Victor, you've said that people who are living with obesity or living with being overweight are going to be more at risk of developing type 2 diabetes alongside that family or strong family history. I know that your heritage plays a part. Do you want to say a little bit about that? For people of African Caribbean heritage and legacy, how are we impacted?
Okay, so let me just first of all talk about the link between type 2 diabetes and obesity. Okay, so first of all, the data suggests that children with type 2 diabetes are more likely to be overweight or obese. And the data says about 80% of children below the age of 19 are obese and 10% of them are overweight, i.e. those with diabetes are more likely to have issue with their weight. That's one thing. And this is more commoner in people of the ethnic minority because often weight are slightly more preponderant in this group of people compared to the other ethnic. So diabetes is usually complex. As we mentioned, family history, age, ethnicity, and the background will play a role, but obesity play more role.
Thank you so much, Victor. I think this emerging pattern of type 2 diabetes in the young, first of all, I'm so pleased we're able to raise awareness about it. I don't think there is really much awareness, and we heard earlier from Dr. Jean-Claude that there was a 40% misdiagnosis rate. I think that potentially was part of it for type 1, because you're having someone who's very young, much younger than the average diagnosis age. And I guess maybe it was more challenging to diagnose that person as having type 2 diabetes when it was just so rarely seen. So I think that's hugely pleased that we were able to raise awareness and let people know that being of Black heritage or South Asian heritage increases that risk significantly. I think that's a take-home message. And then for me, the final take-home message from that is that reducing the amount of fat an individual carries, especially around the tummy, and knowing that especially in South Asian communities, but also to an extent in Black populations, that fat around the tummy is especially harmful, shall we say. So knowing all that we've learned across the various episodes, that's another thread. It seems to be another red thread about the more we can do to reduce our excess weight, the better. But and Joan, on that 9th episode, what are your thoughts, your take on it?
Yeah, absolutely. So at another part of the episode, and obviously I would reference people to go and have a look at the episodes, because we've only got snippets here, that Dr. Victor Oguntolu had shared with us that about 20 odd years ago, so the turn of the century, this wasn't really known about. Early onset type 2 diabetes. However, in this 20 odd years, the incidence in those who are less than 40 of developing type 2 diabetes is rising at a greater rate than those who are greater than the age of 40. So it is something that is emerging. It is something that we have to become more aware of, and hopefully with things like this episode, people will become more aware of it. And also the implications, the potential implications of developing type 2 diabetes at an early age in terms of the potential risks of developing complications, and also for healthcare providers to have, again, that open mind in terms of diagnostics, in terms of, clinically have that open mind. Somebody as young as in their 20s may have actually developed type 2 diabetes. I've seen quite a lot of it, but I think we have to just maintain that open mind. Yeah.
Absolutely. And I think we've seen across all the episodes how quickly things seem to move in terms of clinical practice, treatment. What a wonderful time we're in. I know this time has challenges outside of this, which we won't delve into, but also what a wondrous thing that we have to support people as they're going through their journey with diabetes. So, Joan, another silly take home is your fantastic outfits as we've been going through. Honestly, I need to up my game hugely. But Joan, thank you so much.
Thank you very much. You can only see the top bit of it.
The top bit is
so
impressive.
you don't know what the rest of it looks like.
I love that. But,
and I just want to say a wonderful thank you to Diabetes Africa and the whole team. I mean, for pulling together yet again another spectacular series. And, we'd love to say it was by design, that this thread of lifestyle medicine, of health inequities, of intersections, of holistic medicine was designed at the beginning of this series. It didn't quite work out like that, but it has worked out wonderfully well. And so I hope people will go and have a look at the episodes, because there's just so much information there. And as I say, I'm thankful that it seems to get better and better as we go on.
I'm sure there's questions that people have that we're going to address now, but whilst we're doing that, huge thank you to the incredible speakers that we've had. Top-notch quality across the board. I'm absolutely delighted, and a huge thank you to them. And let's get into the Q&A. So I'm going to give a few moments for people to put some extra questions they have in the chat, and then we're going to kick off.
Amazing. Thanks so much. Diving straight into the Q&A with such a fantastic question from Ateneo. Dr. Joan St John, we have: what constitutes healthy living with diabetes? Goodness me. That is an incredible question. I'd love to hear your thoughts on that.
Thanks very much, Bernadette, and thanks very much for the question as well. So I think I would say that healthy living with diabetes is what that individual determines their healthier life with diabetes is going to be. And I think one of the themes that we've had throughout the various series that we've had, and this was the finale of the fourth series, is it is an individual's condition. It is not a one size fits all, as we've heard this evening. That person has to determine what is going to be healthy living for them. So it might be that they're going to be more active. It might be that they're going to make some food changes. It might be that they're going to try and lose the 5% of their weight that Dr. Itunu spoke about in one of the episodes. It's going to look different for everybody. And we can't determine that. And I think that's an important message, actually. It's not for us as healthcare professionals or providers to determine that for somebody living with the condition.
Absolutely. I agree that it's very personal. I also feel like it's to what the individual is able to prioritize or feel is important to them. It might be, are they able to play with their grandchildren or their children? Could it be that they're able to walk up the stairs unaided? Is it that they're able to enjoy the foods that they so love in a way that's manageable? But I think in the lifestyle medicine episode, in the women's health 3 episodes that we had, I think in each of the episodes, our experts have actually made mention to something along those lines. So Atenio, or if anyone else is interested in an answer to that question, each of the episodes we touch upon that because it's such a common question.
Can I just add another thing as well, Bernadette, that I think, we speak about lifestyle medicine, we speak about the holistic way of addressing this condition. Within that, we are going to talk about evidence base, we're going to talk about research. So there is some evidence base behind what we as healthcare professionals would call targets, what somebody living with a condition might call a goal. And so there is evidence around that as well, but that has to be a shared decision. So you make that with the person living with the condition. Is not for us as healthcare professionals or providers to say, this is the HbA1c that you should be aiming for, this is the blood pressure that you should be aiming for, this is the weight that you should be aiming for. We can advise and then people make their informed choice.
Absolutely. I wholeheartedly agree with that, Joan. Moving on to a poll result that I'd love to discuss. We saw Dr. Itunu Johnson talking about hormonophobia. And I launched a poll that says, do you feel that people with Black heritage are fearful of external hormones? And the results were, I think I can put them on the screen. 23% said yes, 50% said no, and 62% said not sure. And one of the people commented in the second part of the question is that there's not much awareness or information about external hormones, and that's where they feel that the hormonophobia is coming from. So, Joan, in your experience supporting people living with diabetes, have you felt that that's true, or do you have an alternate view?
No, I think that there is definitely truth in that. That again, but that may be the face of health inequity. That, why do I say that? Healthcare professionals may sometimes not broach that subject with someone of African Caribbean heritage because they're anticipating hormonophobia. So again, I think that may be the reason why people don't broach it, and that can lead to health inequity. So yes, I think the more we can do about raising awareness, and throughout the webinar series, that's what we've been trying to do. Give people information so they can then either look for more information, but certainly make themselves informed and make an informed decision.
Absolutely. Wholeheartedly agree. Okay, moving back to a question. We had a question from Laura. How to advise patients on the best diet for them in a way that they will adhere to it. And is our whole food plant-based diet the best diet? I have my own views, but Dr. World Foods, Carbs and Cows, I feel like we need to go to you first for this question. I know we have some dietitians in the audience as well, but
Yes.
I would love, Joan, please, what's your view on that?
Yes. Here I come again with it, one size doesn't fit all, and I'm sorry to say that. But, we have the wonderful Nana Okran who did the lifestyle medicine episode with us this series. And I think Nana would say that you meet somebody where they are. And she gave the anecdote of somebody who'd been told about, I think it was potatoes or bread, and maybe Nana can put it in the chat. And this person was from the African continent. I can't remember exactly which country. And it was just so out of their cultural sourdough bread. Thanks, Nana. And also chia seeds and couscous or something like that was not part of this person's cultural makeup and experience. And you have to, I've always said quinoa, that's it. I've always said that you have to have some curiosity as a healthcare professional, learn from the person in front of you. And this is so key when we're talking about food and food advice. You do not know unless you ask the specific questions what food that person is eating. And if you don't recognize their food, go and find out about it. Don't assume that they know what quinoa is or they eat quinoa or sourdough bread. Find out what it is they're eating. And then when you've informed yourself, you can give them your more informed information about what is going to work for them. As a general rule, certainly the less processed the food, and we're not talking about things like yogurt. Okay, let me just clarify that. But the less processed the food, because one of the ones I always use is like chicken nuggets. It doesn't look like chicken. So, when you can have food that looks like the food it's supposed to be, the chances are that's going to be healthier for you.
Absolutely. Agreed. I think we all down in our heart know if it's a blue luminous drink. That is probably not the most natural thing, but I completely agree with you. Whole foods and the best diet being whatever works for that particular individual. I know Nana and her team have done this, and others as well, having a trial of a continuous glucose monitor, which looks at how an individual person responds to different foods. I know they say oats are very healthy, but when I did a trial of a continuous glucose monitor, my blood glucose went to the moon with something that was meant to be healthy. For other people, it doesn't do that. So that whole individual tailoring is so important. And if I may show, one of the questions that I asked while we were presenting is, I asked the audience what particular aspect of lifestyle medicine they felt was the most important. There was no real standout, which means that people feel that essentially they're all important. Interestingly, social life was the least popular, which was a surprise to me. But it is just showing how difficult it is to actually get to address all the different aspects. I thought sleep would be 100% of people. And then interestingly, when I asked about rest, oh, it's not letting me share. Sorry, 1 second. Yes, when I went to rest, most people said that they were not rested. They were not sufficiently rested. So it does show that probably sleep is one of the biggest drivers of health and of, if we're looking at holistic medicine, probably where people could try and start. On that, Joe, any comments before we move on to another question?
So one of the comments I would have, two comments probably. So one of the comments I would have is I celebrate when healthcare professionals have that curiosity and then go and look and delve deeper into this. And I know in certain areas I've come across like secondary care, as it happens, dietitians, nutritionalists, healthcare providers who will look at the community that they serve, examine what foods that community is eating, and then go and get the relevant information, nutritional information about those particular cultural foods. And yes, we try to do that with world foods, and I celebrate the fact that other people are also trying to do that based on the communities that they serve. So I think you use the tools you've got, and you said about continuous glucose monitoring. It's not possible for everybody to do that, but my goodness, what a wonderful window into what happens when somebody eats their own food, whatever that happens to be, from their own culture, and how that affects their blood glucose. And they can then see that. It is a great tool. So use what you can, whether that's finding out about the food, whether that's continuous glucose monitoring, to assist that person as best you can.
Absolutely. And on that theme of, I guess, into personalization and adapting to an individual, we had a question from Delisly about how could we guide people through intermittent fasting safely. I'm assuming that's in people living with diabetes. We know it's going to be very individual, and it will depend on what subtype of diabetes the person living with, their age, if they have any comorbidities like heart disease, foot complications, kidney disease, like the whole spectrum, how their eye health is as well. There's a reason why, just to our audience, we're not dodging these questions, but we just understand how complex diabetes as a wider condition is, and we want to make sure that individuals are getting the best care. So as an example of just one of those few things I've mentioned can drastically change the advice that a person is given. Joan, have you got anything else to add to that particular question?
Yeah, sure. It also depends on what medication they're taking. So if they're using insulin, if they're using one of the sulfonylureas, these are just types of medication for those who are not familiar with the classes of medication that we're talking about, that can drastically lower your blood glucose. So if you combine that sometimes with things like intermittent fasting, increased activity, you could end up with a very low blood glucose. And so just adding on to what you've said, Bernadette. So again, it has, how can it not be individualized? Diabetes care has to be individualized. Yes, we know that there are broad sweeps of things that are applicable to everyone, but it has to be an individual conversation with your healthcare practitioner provider, and together you work out what's going to be best for you as an individual.
Yeah, absolutely. Thank you for adding in there about medication. I didn't mention it the first time. Right, let's go back to the polls because we had some fun, really interesting answers. So let's go back. I was fascinated about the awareness of ketosis-prone type 2 diabetes. The reason why is because, I mean, perhaps, Joe, we need to do our job a little bit better because we've done quite a lot of work on this theme, but we certainly need to get the word out there more. Yeah, it's still not as well known as we'd hope.
Yeah. I think sometimes it's known by different names, and those names aren't necessarily names that I'd want to repeat. So maybe the fact that we are using a sort of clinical term, maybe why people weren't recognizing it. As I said in the episode, as a clinician in primary care, quite often I've recognized it in terms of somebody coming back, having been unfortunately admitted to hospital because of that acute diabetes related emergency, needing all the treatment that you need in secondary care for a condition like this. But when they come back and they're over that episode, drastically and dramatically reducing their requirement for insulin. And that can be within weeks, it can be within months. And so certainly you are very aware then that this person has this ketosis-prone type 2 diabetes. So I hope that people will go to the episode, those who haven't heard about it, who want to learn more about it. There is a lot of information there, and I'm pretty sure we've talked about it in other episodes where we've talked about type 2 diabetes.
Absolutely. And once it's relating to a question that Dr. Sakia mentioned about lifestyle and complications. We have a question here about foot care, which is related to another complication. I guess just raising the awareness that number one, yes, there are diabetes complications. We have, if you look on our YouTube channel, we've gone through most of them, I would say. We've covered a great deal of them if you'd like to find out more information. But we haven't talked about type 2 diabetes remission. And I feel that we should put it out there as a hope to people that are living with type 2 diabetes. It's not for everyone that they can put type 2 diabetes in remission, but we should raise awareness of its possibility. Now, Joan, I don't know if you want to give any guidance. We have events dedicated to this on our YouTube channel, but if you wanted to discuss that.
Possibility of remission being an opportunity for people.
Yes.
Absolutely. I think so, because it was a game changer for anybody working within the field of diabetes and anybody living with the condition. The fact that this condition, which was thought to be a progressive condition, could actually be put into remission, or some people would call it a reversal. What we don't call it is a cure, because if the circumstances that were there prior to the remission or reversal reoccur, then the type 2 diabetes can come back. It is a possibility, as Bernadette said, it's not for everybody. It wouldn't necessarily occur with everyone, but you can increase the chances, it would seem, from all the evidence, by the percentage of weight that is lost. The percentage of weight that is lost, again, seems to be almost individual, not fully, but we know that there are critical weights for each individual. And certainly weight loss is one of the most important things that can then bring about remission. But it doesn't always occur with everyone. It doesn't last forever with everyone, but it is a possibility. And I think we have to, that's such a positive hope that is there, but it doesn't occur or can't always occur with everyone.
Absolutely. I love that, John. It's like, okay, let's know that it's possible. Aim for it, but don't feel judgment or blame or failure if it's not possible. And I love that. Let's do one or two questions before we round up. Someone in the team, if we're able to add in the link to the foot care handbook, because we had a question from Juliet about foot care in diabetes. So we've got a resource for to support healthcare professionals, and it could be helpful to people living with diabetes with dark skin tone. I think that's a fantastic resource. We'll hopefully share that. Joan, is there any aspect you'd like to cover before we round up for the series?
Well, one of the things I think we have to celebrate again is the Foot Care Handbook. The Foot Care Handbook is free to download for any healthcare professionals, anybody living with the condition, anybody who feels it would be helpful, because certainly in medical school, and I think for some other healthcare professionals as well, it wasn't the case that we were taught how conditions would look in the feet of people who had what we've called dark skin. And so this free to download handbook has been downloaded, I think, about 50,000 times. Am I correct?
I think so.
Thereabouts. Yeah, thereabouts. So really, it's very comprehensive, and it is exceptionally helpful, I think. And if you know somebody who would benefit from it, because one of my main themes is each one teach one. The whole reason why we do the webinar series is to inform healthcare professionals, inform people living with the condition, inform carers, inform anybody who's interested in this condition, to have more information so that we can improve care. So each one teach one. So the handbook is actually a really good resource.
Absolutely. Thank you, Joan. From my perspective, I think to round up, a huge thank you to everyone who's joined us this evening. Oh, yes,
Before you do that, Bernadette, there was a question, if you remember, about occupational health, and
oh
I think it'd
yes, yes.
be I think it'd be really useful to um, ask that question, just because it's not something that we normally would address.
Okay, yep, I can read the question. So, we had a question from Jackie. Occupational health challenges. What support measures are recommended for the workplace?
Yeah. So, because I think it's really important to highlight this as a primary care physician and for other healthcare providers who are on this episode, attending this episode as well. Sometimes there is a gap between what happens with the person living with the condition at work and for you as a healthcare provider as well. So the way I used to experience it is sometimes people would be asked to wear particular footwear at work. And that footwear may not be compatible with somebody who's living with diabetes. It may be too heavy or too rigid, or not allow the skin of the feet to breathe sufficiently. And you would be called upon to ask. They would ask you to give like a letter so they wouldn't have to wear it. But it would be so much better if we could communicate with occupational health to say, how can we make this work to keep the person safe at work, but also to do the best for their condition. The other thing I think I mentioned to you, Bernadette, is with driving. So there are people who are driving buses, well, not so much the trains, but yes, trains sometimes as well, who I would think maybe this level might be a bit better. Maybe we should aim to try and get this a bit improved. But they would say to me, oh, things are fine. I've passed my medical at work. And so for me as a primary care physician, I would love that we could have more communication between our health service and occupational health. I think it should be a joined up service, and that, what goes on at work, as a lot of people spend the majority of their time there and in the NHS, is actually joined up as opposed to two separate systems in a way.
Absolutely. And even in people whose workplace doesn't have occupational health, I think it's also about letting the management team or your manager be aware of your condition, asking for adjustments where required. I know some people who work in shifts were essentially told that they couldn't eat during their shift. And it's like, well, if you're living with diabetes, like, well, no, type 2, and your blood sugars are going down, you need to be able to manage that. So I think it's about we talked about this before. We've had an event on this specifically about advocating for oneself, knowing what are rights or what are the options for someone in the workplace. I think it's incredibly important. And like you mentioned, John, even to be safe,
Yes.
It is genuinely a safety issue. And so I think, that's a great question. Thank you for drawing my attention back to that.
And the other thing is, sorry to Bernadette, we may have to have an episode on this. Is that a lot of people unfortunately feel shame or stigma and do not let their workplace know that they are living with diabetes. So this is the other aspect of work and living with diabetes. Some people will not let their workplace know that, and then they can run into different problems because those provisions aren't made for them to keep them safe and well at work. So yes, we may well be coming to you, Dr. Jackie, to do an episode on work and living with diabetes. Yes.
I think it's a great theme. I know, I believe the Royal College of Nurses in the UK are also looking into this, as with their huge workforce. There are many people living with diabetes, and so it's great that this is getting more momentum. So I'm actually going to come back to you, Joan, because I don't want to round up because you might think of something else. But is there anything else you want to speak about before we round up for this season? I cannot believe it.
Yeah, fourth season. It's absolutely incredible and it's wonderful. And I almost feel like we need to start revisiting some of the things that we did in the
Yeah,
first
yeah.
series. But there are so many more issues, subjects that need to be addressed, that information, awareness needs to be raised,
Mm-hmm.
information needs to be given. There is so much more that we need to do. We would like to do certain topics that we haven't done yet. We would welcome if you are really keen for us to do particular things as well. Please suggest that to us. But I think that, I'm looking forward to next season. I'm really grateful for the four seasons that we've done so far. And I think that, yeah, together with all the people who attend and participate, the experts who share their knowledge, we can actually do something to improve the care of people
Mm-hmm.
who are living with diabetes.
Absolutely. I've launched a poll in response to your question, Joan, asking people what topics we should cover the next season. Whilst people are answering that, and please do answer if you're able to. I first of all want to thank everyone who joined today. I would like to thank the incredible speakers that we've had across the season and previous seasons. As Joan would say, quality we have had the season. The knowledge that people have shared has been incredible, and we should acknowledge their contribution and give them a huge thank you. My team member Jack has looked for me, and we have passed 300,000 views for Diabetes Health Matters on YouTube. We are aiming for a million. So a million is our target, but 300,000 views, I think we should be incredibly proud. And that is just on YouTube. That is not on our social media platforms. That's not anywhere else. So we're so proud that people are engaged with the content, and we're so happy with the engagement that we've had. Joan, none of this would be possible without you. You make the episodes engaging, interesting, funny. Like I said before, your outfits are always popping. So that's a huge thing. But honestly, I think the way that you're able to get the information out of the guest speakers that we have is just unique. And I know I call you diabetes Oprah, but maybe Oprah should be non-diabetes Joan, honestly, because thank you so much for the dedication. It's an awful lot of your time, and people do appreciate it. So huge, huge thank you. And really looking forward to doing a next season. I think we can, like you said, revisit some of the topics that we visited 4 years ago. I cannot believe I'm saying 4 years ago, but 4 years ago, things have moved on. And yeah, it's just been an absolute joy and a pleasure. Thank you so much to Eli Lilly and Company for being the one who were with us at the very start of this, believing in what it is that we were trying to do, and for continuing to support what we do. We are changing people's lives. We are having an impact, and we want to grow that impact. Thank you also to Eamon Irini for joining Eli Lilly for this season. And on that note, and thank you to my team also, who put together what I believe are a very engaging, entertaining, well produced, put together episodes. So thank you, Jack and Greg. Joan, over to you to round us up.
Thank you so much, Bernadette. Oh, you got to me. So I want to say thank you to everyone, particularly the Diabetes Africa team. It's a small team who do phenomenal work. You produce this webinar series, these 4 series of Diabetes Health Matters so professionally, so well. So really, really grateful to you guys for that. Really grateful to all the participants, because as you are participants, because you participate in what we're doing and you help us to find the topics, discuss it, you push us, you challenge us, you ask us the questions, you stay active in the chat, you share your knowledge as well. So we're really grateful for that. Really grateful to the amazing experts that we've had. They have been phenomenal. They are just, they give of their time, they give of their knowledge, they give of their passion for this condition, because what we're trying to do is just make things better. So we're looking forward to next season. Please spread the word. 300,000 is huge. But yeah, we're going to go for the million. And so each one, teach one, please. You direct somebody you know who would benefit from this to our YouTube channel so they can share that information with somebody who might benefit from it as well. So have I left anybody out? Okay, well then, thank you so much. It is an absolute privilege and an honor to share this space with the wonderful Dr. Bernadette Adeyileka-Tracz, the whole team at Diabetes Africa, everybody who attends, and all the experts. So watch the space. We'll be back, Series 5. And I think you've actually given us some ideas about
Yes.
what we need to be doing. Yep.
Yes.
So here's to our future. Together, we're going to make things better. Thank you, everyone.
Amen to that. Have a lovely evening or afternoon or morning, wherever you are in the world. Thank you so much. We look forward to seeing you the next season. Bye.
Thank you.
Bye.
Bye-bye.
Bye.
Bye-bye.